of our guest speaker today. I'll just share actually how this actually came about. So I was at probably Academy or one of the meetings and having drinks with one of my old classmates from New York. She practices in the Philadelphia area now, and she was telling me about a case she had, a young guy with possibly, if I maybe in a traumatic cataract. It was white. She took him to the OR. She started the case. She tried to put the cystotome through the capsule, the anterior capsule, and it was like a rock. It was like a fibrous material. She couldn't do anything with it. And she considered other approaches and wondered if she'd try to cut it. But as she had even just tried the cystotome, the lens was rocking back and forth, and she chickened out. She said, "I'm going to close that up." And I said, well, what did you do? Well, she goes, I sent it to this guy, Steve Safran. I said, "Oh, Steve's in your neighborhood." He goes, "Yes, I've known him for years." And I said, "Well, that's fabulous. What did he do?" And he said, "Well, not only did he do the case the very next day, he sent me a video of what he did." And I heard that and I thought, this sounds like an amazing speaker to speak to us. And I had seen him speak before, but I didn't realize until I did this introduction that he has a YouTube channel with over 260 videos on complex surgery. So this is a huge resource for our residents to watch as they're learning different approaches. So Dr. Stafford did his residency at New York University and a fellowship at Cornell at Duke, and he currently practices in Lawrenceville, New Jersey, with a special interest in complex cataract surgery, as well as lens exchange, endothelial keratoplasty, and iris repair. And he also performs a broad range of glaucoma, cornea, pars plana vitrectomy, and even plastics procedures on a regular basis. Now, he has authored and co-authored many peer-reviewed articles in the literature, and he's well known as a prolific writer on CARANET, the Ascaris Cataract List, and now iConnect. He has been an invited guest lecturer at many grand rounds, including ours today, national, international meetings, and he was the Wolf Foundation lecturer at Iowa in 2019, gold medal lecturer at the AUSCRS meeting in New Zealand, as well as speaking at Yale, University of Pittsburgh, Mississippi, Northwestern, and many other teaching programs and meetings. And I encourage all of you, after watching his talk today, to check out his YouTube channel and his many videos that he's put up there for teaching and instructional purposes. So welcome, Steve. Thank you very much. I'm sorry you couldn't make it up in person. It would have been great to meet you, but thank you for coming virtually. I think this is going to be fabulous.
Thank you. Thank you very much for having me. I really appreciate it. Can you see my slides? Is my screen up?
Yes, we can see them.
Excellent. So I'm going to talk about anterior segment surgery plus pars plana approach, middle ground or out of bounds. Okay. And I'd like to thank John Lloyd for inviting me. These are my disclosures. It's not a long list. I speak for J&J now and then, but mostly then. So in my practice, I get referred a lot of cases like these, dislocated lenses and have to be replaced and repositioned, sublux cataracts, socked in anterior chamber lenses that need to be removed. And they actually have complicating things like corneas that have gone bad, scleral thinning I have to work around, glaucoma or previous glaucoma surgery, iris damage that I either need to fix or deal with. And many of these patients come from pretty far away. So there's a lot of information that I need to gather to make complex decisions and plan on short notice. Bringing these folks back for reevaluation may be difficult or impossible. If you don't get everything on the first, go around, you might say, oh, I should, bring them back and do this. You can't because they're far away. And I have to be prepared for a wide range of intraoperative possibilities and surprises that may happen, like the one you mentioned earlier. So here's a patient referred by a vitreoretinal surgeon for an UGG syndrome. And you can see the lens is dislocated, and this looks fairly straightforward. But a lens that looks like this in the office may look like this when the patient comes in for surgery a few weeks later. And, this is what I found when I took him to the OR. The lens is sitting on the retina. You can't have patients flying in from wherever they are, and then, you lie them back on the table and cancel the case. You have to be prepared to deal with these things. And I'm in solo practice. I work by myself. I don't have any assistant or anybody working with me really. So I can't, have somebody on call to just come in and help me out with this who's, just happens to be in another OR. So in this case, I brought the lens up and did Yamani, which is, something that I do fairly frequently. I think I also did a goniotomy here because he had some glaucoma. Here's a patient referred with ectopia lentis, scheduled for phaco IOL with capsule support, capsule retractor, CTR, sutured segments. But by the time I get him to the OR lying flat, the lens looks like this. And at this point, it's a different kind of a case. And I kind of need to be prepared, or feel I need to be prepared to handle this. And my practice has kind of gone in this direction over the years. This is this guy, 1 week post-op, he's 2020. There's this refractive outcome. I'm a big fan of Yamani. I like this procedure a lot. I'll be talking about this a little bit more. Here's a traumatic cataract patient referred to me in 2022. Plan is capsule retractors, Gore-Tex sutured ring, toric IOL. He's got a little, like 2 diopters of astigmatism, so plan on doing a toric. But the patient got COVID and the case was delayed. We rescheduled it. He came back 2023, 6 months later. And now the lens is hypermature, swinging back, vitreous in the anterior chamber. So this is a different kind of case. It's pars plana vitrectomy and pars plana lensectomy. And so this is what this patient looks like on the table. And I mean, I know I might try to save this bag and use it and put a lens in the bag. And to be honest, I mean, I think I could do that if I wanted to, but I got to be honest, I think a capsular bag without zonules is just a carrier for lens epithelial cells. I don't really think it serves much of a function if you're going to have to do a vitrectomy anyway, which in this case I clearly had to do. And, unless you need a high power toric or something, I don't really think it benefits you that much to have, a lens sutured with all these segments and rings versus just doing Yamani. And Yamani is certainly much faster and cheaper. So here I'm using a fragmentome and doing pars plana lensectomy for the fragment that fell in back. And I find this much more relaxing to do actually than, trying to save a bag where every little move, you could screw the pooch on that bag. This, you have all the room in the world to work. You can clean everything out. You have there's a technique for dealing with this. It's not that much different from phacoing in the anterior segment. If you use a vacuum to hold it to the phaco tip and then only the power you need. And here I did LRIs to deal with the astigmatism because I didn't use a toric lens. And day 1 post-op, he looked really pretty good here. So where did this start? I actually have been around a long time. I'm 63 now, and I started with pars plana vitrectomy as a cornea fellow at Duke in 1991. Mike Coble, my mentor there, was a real advocate of the pars plana with trocars for anterior segment work. Mockimer was the chairman there. He was the father of vitrectomy. McEwen, Tiedemann, Dewan were all on retina faculty and just fantastic guys. And they were very happy to teach me and work with me as a cornea guy. We did combined cases with retina where they would do the posterior segment work and I would suture in a lens or do whatever I did in the anterior segment with them. And the advantage of having trocars and pars plana ports became very obvious to me when I did these cases. I was like, yeah, this is the way to go. You have so much control. So I started staffing cases with the residents where they would drop the nucleus and I take over, get it, suture in a lens or whatever. So I took this technique or this approach with me into private practice. I started my practice in '92 in Lawrenceville. And still am in solo private practice. And this is a recording from 1994. It was a Video Journal of Ophthalmology, Complications and Comments. A much younger version of me.
In this Pearl on Nightmare Cases from Hell, Dr. Stephen Safran presents critical advice in the surgical management of a cataract that drops to the back of the eye during phacoemulsification. This includes the decision to make a 3-part pars plana vitrectomy to remove the remainder of the fallen lens from the posterior segment.
This is a case that I think is probably the most controversial in the series. A little more hair then, So the lens whizzed before we had Vision Blue. Couldn't see my rexus. Lens fell and back. This before we had self-sealing trocars. These are 20 gauge trocars, and we didn't have the biome indirect system. 20 gauge vitrectomy. But there's a lens sitting on the back of the retina. And I did my vitrectomy, didn't use the fragmentome to break up the lens. Then a cortical cleanup is done through the pars plana, preserving the capsule, and we're able to put a lens in the sulcus and achieve a very good result. This patient was 20/25, uncorrected 1 week out, and she had a really unremarkable post-operative course. And so doing these kind of cases I became a big believer that, if you drop something like a nucleus or whatever in back and take it out right away, there's much less inflammation and problems for that eye than if you do it 6 months or a year or whatever later. I mean, doing it right away, taking care of it. I found these eyes were, very quiet. Not that I drop lenses that often, but not having to wait around, I just felt that, these were pretty uneventful procedures for the patient. They did very well. So here's a case now from this past year. It's a patient referred the day after complicated flax. One of our colleagues on CareNet actually was asking about using femtosecond laser flax for a patient with RK. Of course, I'm not a big fan of femtosecond laser. I didn't think it was a very good idea. She's got discontinuous treatment of the anterior capsule, which led to radial tear. The lens is unstable. She's got a lot of nucleus fragments in the anterior chamber, and the rest of this is in the vitreous. The lens is unstable. One haptic is in front of the anterior capsule. The other haptic is behind. The optic is posterior to the radial tear and threatening to go south. And so this is what it looks like. You can see down here, there's a chunk of nucleus. So, I get these kinds of fairly frequently, and I have to handle all of the issues and problems. With these techniques, I'm able to do this, where first I'll remove that fragment from the anterior chamber with the vitrector, then go ahead and do a pars plana vitrectomy. And I support the nucleus as much as I can with the light pipe. When that's done, I complete the vitrectomy, use a fragmentome to take care of the rest of the nucleus, gobbles it up pretty easily. Again, using the vacuum I need to hold it to the tip, and then just pulsing the phaco like I would in the anterior segment. If you step down too hard, it'll just push the nucleus away. Why not use the lens that's in there? Well, it's an Acrosoft. I don't like Acrosofts for a lot of reasons. Also, the haptics aren't curved properly for what I do with the Yamane. It was the wrong power. It wasn't adjusted for RK. So I adjusted the power, put the lens that I want. There's a little iris defect here. I'm going to use a little bit of a mini running suture here, a hemicerclage type of suture. Now I'm using a little tip from Ike Ahmed, the thermal cautery to shape the pupil a little better. And this guy did very well. Day 1 post-op, he's 20/50 uncorrected. So is pars plana vitrectomy a prerequisite for intrascleral haptic fixation? Yeah, I personally, I think it is. All your manipulations are behind the iris, so you have to clean out the vitreous behind the iris. I think an infusion line is critical for Yamane because you need a firm eye for controlled needle penetration. It allows for precise control of the needle tunnel length by standardizing your IOP. If your IOP is very firm, you're going to tend to have a shorter tunnel. Very soft, you're going to tend to have a longer tunnel. By standardizing that, you control your tunnel length. And I think it prevents choroidal detachment, reduces your risk of bleeding, and it gives you much better visibility and control during the docking procedure. Why pars plana infusion? Well, it allows you to isolate the anterior segment and cornea endothelium, as all your flow is going to be posterior to the iris. So you can fill the anterior chamber with viscoelastic and keep it there. You don't flush it out with your infusion. It gives you much better visibility and control, less endothelial cell loss, and better control of bleeding and all the intraocular contents. And also, you can use the infusion as a surgical tool to push out some ring material to stop bleeding. But there are some caveats to pars plana infusion. You have to avoid the trocar retracting into the suprachoroidal space during surgery, and that can happen when you manipulate the eye. So what I do is make the trocar tunnel for my infusion line a little bit shorter, a little bit more perpendicular. I stereotape it firmly in place, and I try to keep an eye on it throughout the procedure. It's also helpful to turn the infusion off during certain portions of the procedure, such as injecting the IOL and cutting the lens in half. So I use a foot pedal control, and I use the infusion on and off, maybe 20, 30 times during these complex procedures. And you really need, again, to pay attention to the trocar insertion depth and sclera as you manipulate the eye throughout the case. So this is a one-eyed patient from Texas. She has an anterior chamber lens, is referred to me with the early cornea edema, which is just peripheral, and CME. So we're going to take this lens out to a self-sealing incision, put our Zeiss lens in, and you notice that the first haptic I'm able to dock, but on the right side, her orbit rim, the lid is in the way. So I'm going to rotate the eye a little bit so I can get some access so I can make my needle tunnel. And I'm pulling on my trocar, using it like a handle. What I don't notice is, I notice this looking at the video, I partially retracted that trocar. So now when I'm trying to dock the second haptic, I see this ominous looking shadow. This is an enlarging choroidal. But I recognize this, remove the needle, bring the lens up. Now the other haptic's already out. I'm committed here. I take this infusion line out. I'm starting to realize what's going on. Fill the anterior chamber with viscoelastic and move my infusion line to the other trocar, which thankfully pushes everything back. And now I can, because I have a self-sealing incision, I have control, I can go ahead, dock my second haptic and finish this case. And this patient actually did very well. And I'm very grateful, because if I didn't recognize that, I easily could have lost this eye on the table. So that's a demonstration that working in a closed control system is really the key to success in these complicated cases. Your incisions must be self-sealing, infusion for control of the IOP during your maneuvers, and only perform intrascleral haptic fixation in combination with a well-done vitrectomy. So here's a case that kind of illustrates some of these thoughts. This is a monocular patient. I just did this case about 3 weeks ago. It's a monocular patient referred with a failing 50-year-old PK graft. This graft was done 50 years ago by Leibson. He has cornea edema, stromal haze, 15 diopters of astigmatism. The lens bag complex is dislocated onto the retina. The axle length's a little over 27 millimeters. He's had a buckle for a MAC on RD, but he hasn't been vitrectomized. He's actually getting by with this eye. He's 20/80, but the vision is getting worse. He has difficulty functioning now. One of the reasons he's getting by is because his Ks are like 52. So even without a lens, he's, pretty close to plano. But he's not going to be that way when I do a graft on him. So the other eye is bare LP. This is the eye he gets by with. The other eye is a chronic RD. So my first thought is, look, I'm just going to do a PK, stage the IOL exchange, do the minimum amount possible, get this guy seeing better, then come back and do the lens exchange. But then, I was thinking about this case. I started talking to my colleagues, and I'm asking, most of them said, yeah, I agree with that. Just do the PK. But I started talking to my colleagues in retina, and I'm saying, this guy's going to need a vitrectomy. What's safer, an open sky vitrectomy or a closed system vitrectomy in a patient like this? And I thought a closed system vitrectomy would be the way to go if we're worried about safety. So I said, okay, let's go ahead and make a peripheral clear cornea incision and go ahead and do my vitrectomy. And here I can see the lens bag complex. This is my trocar, my infusion. It's always nice to see that, you're in the right place. Look at this Acrosoft lens, how hazy and shot full of subsurface nanoglistenings. The lenses get very hazy over time. I take them out. So here I brought this up. I'm cutting this in half, taking this out with all the Summerings ring. I'm using my infusion to burp this material out. There we go, burping all that out. Now I'll scrape the cornea epithelium, which I could have done earlier, would have improved my view. Now here, I'm using an AR40. Most of us have moved away from the Zeiss 602. We're using the AR40. And it's a little harder to dock the haptics on the AR40. They're 180 microns versus 147 for the Zeiss 602. And the haptics melt a little differently, but I don't have to worry about the rotisserie phenomenon. I bring the pupil down with myostat, do a peripheral iridotomy, put my fluorine ring on, trephinate, do my graft, and this is the end of the case. Now, this was done under general anesthesia. So the guy woke up, I went out to recovery, and I interviewed him really quickly. The right eye is the one he sees with the left eye's out.
Yeah, I see fine. I see your phone. I even see the little camera in the back of the phone.
Great, great. You know what this is here? Can you see that?
Yeah, that's your picture with your ID.
Oh, great, great. So you see pretty decent already?
I see better now than when I came in.
That's fantastic.
That's right. Thank you, Doc.
So I saw him day 6 post-op. This is the last time I saw him. And he's 20/50 with a +3 near vision only. His K's look fantastic. He's a little flat, but that's because of the peripheral cornea edema. And I said, well, why don't you wear 1 pair of +3 cheaters for distance and then just wear 2 of them for near? I sounded a little like Paul Revere, but that worked well for him. So I just called him on the phone. He's doing great. He says the vision's getting better. His K's will steepen over time as that peripheral cornea edema goes away. You want to protect the cornea endothelium throughout the case, but remember, you need a backstop for your viscoelastic to be effective. If you have no lens there, there's just nothing there but vitreous or the patient's been vitrectomized. If you inject viscoelastic, it's just going to fall into the back of the eye like it does here. But here, I can go back, get my lens, bring that up, and when I bring it up, I'll hand it to myself, and then I can use this lens as a backstop to inject viscoelastic with my other hand. And now that viscoelastic's in place and it's going to protect the cornea while I take the lens, cut it in half, and remove it. And you can see the viscoelastic is working for me because I'm using pars plana infusion. There's very little movement in the anterior chamber. You see those bubbles? They don't really move that much. I put the lens in, I inject more viscoelastic, and those bubbles kind of stay there as I do my thing because I'm using pars plana infusion. They're not being pushed out the incision. If the pupil dilates poorly, place your iris retractors posterior to the limbus so they don't interfere with manipulating the lens bag complex. This is a patient from Alabama. He's got Wagner's vitreoretinal degeneration, a 29 millimeter eye. And I put the iris retractor upside down behind the iris, so it's out of my way, pulling the iris back. I can now bring this up, park it in the anterior chamber, cut it in half, and the iris doesn't want to come into the wound. It's held back. It's out of my way. I can burp all this stuff out. This gives me much, much better control than if I had the retractors going through cornea. I can put the lens in, rotate it into position, go ahead and do Yamani. And this guy did very well. If your view is poor in a complex case, remove the cornea epithelium and turn on the infusion to firm up the eye. This will clear up your view significantly. So this is a 37-year-old status post-cataract surgery, 2005 in Malaysia. I just did this case 2 years ago. It's an anterior chamber lens, cornea edema, pressure's 38 on maximum meds, 5 diopters against the rule of astigmatism. And believe it or not, he's got a lens fragment still present in his vitreous from 2005. So you look at this eye and the view is very poor. You say, well, how am I going to do what I got to do here? Well, there's a self-sealing clear scleral tunnel incision to take out the lens. I'm going to remove the epithelium, firm up the eye, and you can see now my view with the indirect viewing system is actually very good. I can remove that lens fragment, do Yamani, melt these haptics. I was able to see well enough to do a goniotomy. And then we did a DSEC graft all in one sitting here. And he had 5 diopters against the rules, so I made an LRI so I can get paid for the procedure. The opposite side, I didn't suture his scleral tunnel. Everything looked pretty good, but his pressure increased into the 50s post-op. So about 3 weeks later, I just put a pars plana tube in. Here's suturing the tube in place. I'm putting the tube through one of my trocar sclerotomy, pushing that through, covering it with cornea. And this patient did very well. 2 months post-op, pressure's 18. His refraction is -1 1/4, -1/2 at 80. His vision is improving. This is now a useful eye, which is good because since I did that, this is what happened to the other eye. His lens dislocated into the vitreous, and I treated that with a vitrectomy and a sutured CZ and the sulcus because he had some capsular support here. I just wanted to do the safest, easiest thing and put a CZ70 in the sulc. So I had to take out a PMMA lens anyway, so I needed a big incision. So this eye was 20/20 at the last visit. Now both eyes are working pretty good. He's firing on both cylinders. Here's a 65-year-old woman referred 1 month after phacogoniotomy by a local cataract and glaucoma specialist. Hand motion vision, total hyphema. He washed it out 2 weeks after surgery, but a month out, she's still got intracapsular blood, pressures in the high 40s on Diamox and the maximum meds. And he sends it to me and says, can you fix this? Here I'm going to put my tube, I'm going to suture my arm tube in place and just kind of get that ready. Tuck the tube back out of the way. And now I move to the side and I'll go ahead and place my trocars. This eye is full of blood. The vitreous is full of blood. The anterior chamber's got blood in it. So what I'll do is I'll remove the blood from the capsule by making a vitrectorexis. With the vitrector, I open the posterior capsule, suck out some of the blood so I can see what I'm doing, then go ahead and remove the blood from the vitreous. And now I can, really see what's going on here. I can see the optic nerve, which doesn't look too bad, by the way, which is good news. And clean this up and go ahead. Now you can see I've made this opening, this circular opening in the posterior capsule. I can clean out the blood. I put my tube in. I like to put these tubes right along the surface of the iris. I want to see them pointing parallel to the iris and actually rubbing against the iris a little bit. I don't want them pointing up at the cornea. Probably I could have put this through the pars plana, but I didn't want to, I just didn't do it. Here I'm removing the viscoelastic with anterior infusion so the lens doesn't come forward. Remove the trocars. Day 1, she's 20/50 uncorrected, pressure's 14. Referred her back to the glaucoma surgeon. 1 month later, he sends me an email. I just saw the hemorrhage lady. She looks amazing. She's off all meds, 16 pressure, vision's 20/20. Thank you so much. And frankly, without pars plana approach, I'm not quite sure how you could do that case. Here's another tip, pars plana approach to assistant optic capture. There's a lot of confusion about optic capture. The optic capture just means the optic is buttonholed through the rexus, haptics on one side of the rexus, with the optic pushed through to the other side. So standard optic capture is with the haptics and the sulcus, the optic buttonhole behind the anterior capsule, and this is for 3-piece lenses only. This is optically equivalent to in the bag. Reverse optic capture is the haptics in the bag with the optic prolapse in front of the anterior capsule. And this is optically equivalent to sulcus placement with greater stability. And this is a strategy we often use to treat negative dysphotopsia. So here's a complex case. The lens is partially in the bag, partially out of the bag. There's vitreous all over. I did my vitrectomy, and now I want to optic capture this 3-piece silicone lens. And the rexus is a bit fibrotic. It's kind of tight. So I'm going to push on this as I retract the anterior capsule. And here I'm retracting and pushing, and it's a little tight, and pop. All right, well, did anybody see what just happened there? Let me play this in slow motion. The optic and the haptic went behind the anterior capsule. So now my lens is just dangling by this one haptic and threatening to fall back. So I recognize this, reach in, grab it, bring it into the sulcus. And now, this is the first time I'd ever done this. I'm going to hold the lens from posterior and pull through as I push. So this stabilizes the lens. Look at how easy that is and how safe to optic capture it now. So this is a technique I use a lot now. Here's a patient referred 4 months after complicated phaco, count fingers vision, lens in the sulcus, lens material blocking the visual axis, seeing me with lens debris in the vitreous. She's got an UGG syndrome from the iris chafing as well. This has been there for 4 months. Patient was referred to me 4 months after the original surgery, not seeing very well. So I'm going to go ahead, vacuum out. After I do an anterior pars plana vitrectomy, remove the vitreous, I can vacuum this cortex out of the bag, go back and remove the dropped lens fragments. This guy has some dropped fluffy epinuclear junk in his vitreous, clean that out. And now I'm going to use the vitrector to shape the capsule opening into an opening that's suitable for optic capture. And this is a technique I really like. I use this a lot. I'm basically painting my rexus opening with the vitrector into a size that's suitable to capture the optic. I can buttonhole this behind the iris, behind the anterior and posterior capsule, which are fused. And this is a much more secure, stable position for the lens. The lens won't move. There's less risk of UGG syndrome. Patient was actually 2025 day one, and this was done 2 or 3 years ago. He's doing very well. This is a very common scenario I see. A patient had a restore lens placed 11 years ago. He's got severe glistenings, a lot of vitreous drunk. This is a 28 millimeter eye, had LASIK 25 years earlier. He was miserably unhappy with his vision. For about a year, I didn't do anything because he was hyperopic. The original cataract surgeon decided to laser the anterior capsule in both eyes, hoping it would change the effective lens position. I'm going to tell you that has absolutely no effect, and it didn't do anything here. So I finally thought, well, why not take care of this? I have an idea of how to deal with this. So here's this YAG laser nick in the anterior capsule. You can see this guy's vitreous is very snotty and syneretic. That's not helping with that old restore lens. You can see here's the nick in the anterior capsule. There's a posterior capsule opening extension from YAG laser, and the blue arrow points to that anterior capsule defect. And if I do anything to stretch that anterior capsule, that's going to radialize and it's going to extend, and I'm going to lose the bag in this 28 millimeter eye, which I don't want to do. So what I'm doing is using my 25 gauge vitrector to erase that nick and smooth it out. And now I can visco-dissect the bag, remove the lens. And these old lenses, this lens has been in there 15 years. You can strip the haptic of fibrosis like I did here, remove this, remove the other haptic. The other haptic I think I just cut because I didn't want to, you know, sometimes you can cut them and then go back and get them. But in this case, I think I just left it. Remove the lens. This is a new 3-piece lens. And here you can see I can now go ahead and optic capture this lens behind the anterior capsule. And again, in a 28 millimeter eye, you put the lens in the sulcus, it might bibble and bobble around. I can go ahead and do the vitrectomy, complete the vitrectomy, which is going to help him to see better. When I remove the viscoelastic, I use anterior infusion because posterior infusion is going to push the lens out of the optic capture configuration. I did some LRIs for him because he had a wee bit of astigmatism. And he was great. He was thrilled with this. And now the other eye is similar problem. Again, he's got the nicks in the anterior capsule. The surgeon was trying to change the effective lens position by doing this. It doesn't work. This eye is actually more challenging because he has a smaller anterior capsule opening. It's going to make it a little bit tougher. So again, I put my trocars in first thing, anterior infusion, and use the vitrector to erase these nicks in the anterior capsule. They're just smoothed out with this on both sides. I can make them pretty much go away. Now, this is a little smaller anterior capsule opening, and in this side, the zonules are not as good. As I go to pull this out, I can feel, you know, this is really, the zonules in this area are kind of shoddy. So I go ahead and cut this, cut the other haptic, and it's okay. Those are socked in. You can leave them. Go ahead and do a vitrectomy before I cut or remove the lens because I don't want to tug on vitreous as I pull the lens out. So I cut the lens, cartwheel it out. Now I'm going to use my 25 gauge vitrector to reshape this rexus so it's the optimum size for optic capture. So I'm using the vitrector to reshape the rexus. Now I'm going to, you can see if I just left it in the sulcus how it would have decentered. I'm going to optic capture it, and I optic capture under the weak area of zonules first. And now I want to rotate the lens so the optic haptic junction stabilizes that area. And to do that, I need anterior infusion. Otherwise, if I posterior infusion, it's going to act like a ball valve, push the lens against the anterior capsule. So here I can use anterior infusion, push the lens away from the anterior capsule, go ahead, you know, do my vitrectomy. And, you know, this lens at the end is very, very stable. And the rexus, you can see, is the same shape basically it was before I optic captured it, that stabilizes that area of weak zonules. Here's a patient with a hydrophilic acrylic lens, severe negative dysphotopsia, status post-YAG. He has a hyperopic refractive outcome. I have tons of floaters since my cataract surgery. He needs reverse optic capture to treat the negative dysphotopsia, but we want to exchange this for a higher power lens. So we want to exchange this lens. I don't want to do anything to keep it because it's a hydrophilic acrylic and I think it'll calcify. It's also the wrong power. And you can see, again, the zonules are really shoddy here. There's a lot of fibrotic anterior capsule. I'm able to, strip the haptics of fibrosis, take the lens out, and cartwheel this out. But now we want to optic capture, do reverse optic capture, because this patient has negative dysphotopsia. So what I'm going to do is take a 3-piece silicone lens, put the whole lens behind the capsular bag, and pull it forward. And when I pull it forward, I'm going to now shoehorn the anterior capsule around the optic. I'm going to grab the anterior capsule with my forceps as I hold it in my other hand. It's the opposite what I did for optic capture, standard optic capture. Here I'm doing reverse optic capture and creating this little cat's eye. And because this is in the horizontal meridian, it's not going to really create any problem for the patient having this cat's eye opening. And we go ahead and do the vitrectomy, and patient did very well. I did this about 2 years ago. He's been happy, and the lens has been very stable. So this brings up this whole topic of vitreorefractive surgery. I want to get into this a little bit. Here's a patient referred unhappy with his vision after cataract surgery, eye stent and YAG capsulotomy. She has a 28 diopter ZCBU, which calculates to a -1/4 predicted outcome. Instead, she's -250. Vision's not very good. Pressure is still 35 on a prostaglandin agent. So what's going on here? Well, does this help anybody kind of figure out what might be going on in this case? Yeah, this is aqueous misdirection. So I treated this with aqueous suppressant cycloplegia. The pressure came down to the high teens on meds, but she's still unhappy with the refractive outcome and her cloudy vision. And this is now over a year after her surgery. This is a great way to visualize the vitreous using the scanning laser ophthalmoscope on your OCT. This is a Heidelberg. And when I show this to patients, they say, oh, yeah, that's what I see. So after 2 years of observation, we decided to do an IZHV. And here's that procedure. I go ahead and put my trocars in. Now, she has only a 21 millimeter eye. So I'm actually putting my trocars in about 2.5 or 2.25 millimeters back and angling them down. I'm not going back 3.5 or 4 millimeters because I don't know where the pars plana begins. So this is one of the reasons she was unhappy. She's got all this snotty vitreous. Go ahead and clean that out. I'm going to have to do a vitrectomy anyway. You might as well do a good one. Bring the pupil down with Myocol. And now using anterior infusion, I'm going to go ahead and chew through the capsular bag and chew through the iris, make an iridotomy and create a uniral cameral eye. What's fantastic, I think, is that her refraction changed from this to this. And she noticed a huge improvement in clarity, decreased in high outward aberration. But look at this. The effective lens position changed from this to this. That's a pretty big shift. And that makes a big difference in a lens that's that high power, 28 diopter lens. And her angle opened up, her pressure dropped, and she's doing fine on 1 drop of timolol. So diffractive lenses have a complex wavefront that's more susceptible to degradation from light scatter. They use steps to create a phase pattern. So instead of being in phase, you have a step that makes things out of phase. And then as you go in this plane, you'll get areas of summation and areas where they block each other out to create nodes. When you put that in the Z-plane with a refractive component, you get multifocality. So this is a very complex wavefront, and anything that scatters light disrupts this complex wave phase pattern, degrades the optics of the system. So to me, these lenses are a bit like these architectural desserts. They look great until you stick a fork into them, and then, the optics of the thing just fall apart. So diffractive lenses, relatively minor issues like dry eye or guttata that scatter light disrupt the complex phase pattern, and it becomes a deal breaker for the patient. So for me, a very common scenario was an unhappy patient referred with bilateral multifocal lens. One eye was post-YAG capsulotomy, and the patient was still miserable. So rather than yagging the second eye, the patient's surgeon referred to me for lens exchange. So I say, okay, let's do a simple lens exchange in the eye with the intact posterior capsule first. Make sure you're happy with that. And usually they're very happy with that. So we go back and do a complex lens exchange in the other eye that's been yagged with a 3-port pars plana vitrectomy. And what do you think happens? Like every single time, they prefer the second vitrectomized eye, and then they want that vitrectomy done in the first eye I didn't do one on. I have to go back and do a vitrectomy. So here's one of my own cataract patients dissatisfied. I put in Symphony Torics, and she says her vision's cloudy. She has starburst and glare. I yagged her. It didn't help. So rather than exchanging the lenses, I did pars plana vitrectomy in both eyes. She needs a toric lens. She's got, I think it's a great refractive outcome. Here I am going ahead. I'm doing my vitrectomy, cleaning out the vitreous. I see there's a tear here, so I vitrectomize around the tear, clean that up, and do some endo laser to laser around that hole, try to protect her from having a detachment. We watched her closely. I had one of my retina colleagues see her. She never did detach and did very well. This is an interview with her a week later.
Here's an interview with her 1 month post.
1 month.
Mary, can you tell me a bit about the difference in vision before and after the vitrectomy?
It's just incredible. It's sharper, it's clearer, and I can literally see definition and everything, which I don't think I've ever seen it. I love them. If they're regular headlights, I'm good.
Do you think that the vitrectomy improved that situation?
Oh, yeah, definitely.
Okay, so
Yeah.
you think that there's a difference in quality of vision,
Yes.
just the vitrectomy?
Yeah, and I don't see any milkiness. It's just great. Yeah.
Okay, excellent. So
I've
you
never
do-
seen this good. I'll put it to you like that.
Okay, great.
So here's a lawyer referred from New York City for lens exchange after surgery with Symphony placement. Plano refraction, blurred vision, glare. I felt this problem was related to the vitreous, so I said, look, let's do a vitrectomy, and if you're still unhappy, we can always exchange the lens. So here, this is very sharply edited. I did his vitrectomy, left the lens in place, and this is...
You felt it was blurry?
Yes,
Did you have a lot of glare, difficulty driving at night?
I did have some glare too, yes.
How about now? We did the vitrectomy a week ago. What's the difference now?
No, it's much better. My eye has become, my right eye has become much more clear. Very pleased with the results. The clouds and went away. Seems like it was like unveiled or something, it's just gone. I'm just really happy with the procedure.
So you feel like now you're happy with this lens, you can
Very
live with it.
I'm very happy with it right now.
Excellent. I'm glad this worked for you. Fantastic.
Yes, thank you.
So this guy was unhappy with the lens. Now he's happy with the lens. So 18 months later, he had a cataract in the other eye. Here's his vitreous. I mean, you could see why this would wreak havoc with diffractive optics. I did his cataract surgery, and I put in the same kind of lens that I was referred the patient to take out. I put in a Symphony, and he was very happy with this. But I, of course, had to clean all this junk up. I did his vitrectomy and cleaned up all this snotty vitreous, and took care of this for him. So this is the kind of scenario I see all the time. Patient referred from Georgia with a PanOptix toric, vitreous floaters, posterior capsule haze. He's unhappy with everything. Halos, glare, poor quality of vision. He's got significant PC haze, but the key is he was unhappy with this lens from the start. He was never happy. So should we yag him? Do a lens exchange? Pars plana vitrectomy? Well, I decided for him, he didn't mind wearing reading glasses. And to be honest, the optics of some of these multifocal lenses just aren't very good. The quality of vision just isn't that good. So even without vitreous problems, a lot of these patients are unhappy. So I decided to take this out, put a monofocal toric in, go ahead and do his vitrectomy. And what I did was I didn't want him to have to wait a month or two to have good vision. So I decided to do a vitrectorexis and remove the posterior capsule haze with the vitrector. And here I am creating a nice circular opening. And what's nice is if this guy ever needs a lens exchange, you can still put a new lens in the bag with that nice circular opening. And he did very well. But what I want to warn you is be very wary of silicone lenses if you want to do a vitrector capsulotomy. Here I'm doing an optical vitrectomy for an artist. And I said, okay, let's get rid of that posterior capsule haze so nobody pits the lens with the YAG laser, because I've seen that all too often. And as I'm doing my vitrectorexis, look at these scuffs forming on the back of the IOL. And by the time I realized that this lens is significantly damaged, and those are permanent. So I've learned, do not use the vitrector for this, making a posterior capsulotomy. So what about laser floater removal? Well, I've been doing this for over 20 years, but it's really only useful for discrete opacities, not for removing this diffuse cloudy vision. So here's pre-YAG laser, post-YAG laser. You can see that floater is gone. Here's another one. You can see the floater over here at the yellow arrow. Afterwards, it's just a couple of little tiny dust particles. But you're not going to be able to do anything with this kind of thing, the snotty, cloudy, turbid vitreous with a YAG laser. For this kind of a thing, you really need to go and clean it out. And this really affects patients with monofocal lenses too, but with the multifocal, it's just compounding their misery. So let's talk about the protective role of the vitreous. Vitreous has an important function of mitigating effective reactive oxygen species. This helps protect other structures in the eye from damage due to them. There's increased risk of cataract and glaucoma, up to 11% after vitrectomy. This is associated with an increased risk of exposure from those structures to these reactive oxygen species. What about increased risk to the retina and other structures in the anterior segment after vitrectomy? Well, many of the dislocated lens bag complex we're seeing are in post-vitrectomy eyes. Vitreous degeneration is also associated, however, with chronic exposure to reactive oxygen species. Exposure to the free radicals breaks down the hyaluronic acid and collagen of the vitreous, causing liquefaction. And as the vitreous liquefies, it loses its ability to deal with oxygen radicals and protect other structures in the eye. And that's why these eyes have already developed cataracts and developed, they usually don't dilate. They've already been damaged. So the aging vitreous that is broken down, liquefied, opacified has already lost most of its ability to protect other structures in the eye from reactive oxygen species. And removing this vitreous doesn't really undermine the ability of the eye to deal with reactive oxygen species the way removing a young person's vitreous does. So performing an optical vitrectomy only for opacified vitreous that's already had undergone incineration and has a PVD, and I determine that by either OCT or a B scan, usually by OCT, and I avoid vitrectomy in younger patients. So I'm not doing vitrectomies for discrete floater with mostly clear vitreous. These are older patients who, they have a PVD and syneretic vitreous that's affecting their vision. That vitreous has basically already lost its oxygen scavenging function. So 30 years after I started doing pars plana vitrectomy routinely in my practice, teaching, talking, advocating for it as the best approach for anterior segment surgeons, it's become a much more accepted approach, but questions and controversies still exist. Is the pars plana approach the best, most controlled way to perform a vitrectomy? I think we all agree, yes, it is, right? Who should be doing anterior vitrectomy through a pars plana approach? Well, I think all surgeons should be trained to do this. It's the best and safest, most controlled way to do a vitrectomy. Surgeons should no longer view performing a vitrectomy as something to be avoided at all costs, as a complication, but rather as an integrated tool for complex anterior segment case management. These are the kinds of cases I see all the time. Patients have multifocals, they have a panoptics lens, they've had YAG laser, they're still miserable, and they need a lens exchange. And in this case, the rexus opening is too big for optic capture. So I'm going to be very careful to try to remove the lens without extending the posterior capsule opening. You'll notice the first thing I do at the beginning of the case is place my trocars. Perhaps I could do this without a vitrectomy, but I don't know. I'm going to just do the vitrectomy so I have control, not worry about seeing vitreous to the wound the next day. I'm going to try to put this 3-piece lens in the capsular bag because it's too big to optic capture, and I don't want to, the rexus is too big for optic capture. I don't want to put it in the sulcus. I tuck it in the bag, do my vitrectomy, and the patient does very well. Here you can see the fish. So who should be doing these complex procedures? Is it easier for a vitreoretinal surgeon who routinely does RDs, injections, membrane peels, to learn about lens selection and management, proper wound construction, astigmatism control, how to address and manage cornea, glaucoma, ocular surface problems are commonly associated with these cases? Or is it easier for a skilled anterior segment surgeon who already knows how to do all these things to learn how to do a pars plana vitrectomy? Well, I think it's easier for me to learn how to do a vitrectomy without damaging anything than it is for a retina surgeon who doesn't do all these things to learn how to be an anterior segment surgeon. What about posterior visualization? Is it a good idea or a bad idea for anterior segment surgeons? This is the acronym suggested by retina specialists, by the way. It's always a good idea to have proper visualization is what you're doing. Posterior visualization allows surgeons to see things that would otherwise be missed. You can treat on the spot or refer appropriately, and allows you to handle lens-related issues and problems that would otherwise be impossible to deal with. Here's a patient with pseudoxfold, dislocated lens bag complex. Glaucoma is out of control on maximum meds, and there's a failing DSEC graft with cornea edema. So the plan is to lasso the CTR you see here, place a pars plana tube, and do a staged DSEC if needed down the road. So here I go ahead and I suture my tube in place. Here's the body of the tube going in. And all these last suitcases, I always do a vitrectomy because if you don't, you're just suturing vitreous to the lens bag complex when you pass your needles through. Here, I like to use a 30 gauge TSK needle, load Gore-Tex in the needle, and lasso each haptic. I make sclerotomies and I connect them with a little scleral groove and create a little shelf there to bury my suture. Here, I'm adjusting the tension. You can see I put that in that groove. It kind of disappears. Hide the knot. Now I'm doing my vitrectomy. I'm trying to clean everything out, and the patient has a little bit of pain. Says to me, I'm having a little pain. So I take a look, and I can see that the patient's having a choroidal hemorrhage. So at this point, I come out, use anterior infusion to push everything back. I take another look, and I can see that there's a hemorrhage going on. I say, you know what? I'm going to get out of Dodge. The lens is secure. I'm going to just remove the viscoelastic from the anterior chamber. I'm not going to put the tube in. I'm going to tuck that away for another time, close my sclerotomy with the suture, get out of Dodge while the getting's good. And actually, this patient did very well. I still haven't had to put the tube back in. His pressure come down to, high teens on meds, and the cornea hasn't failed yet. This was about 6 months ago, and he's pretty happy. He's doing pretty well. But I can always put that tube in later. The choroidal did resolve. The most important thing really is that we provide the best, safest treatment for our patients. We need to work together to do that. Many of my cases are referred by retina groups. I'm fortunate to have retina colleagues that support what I do, and I in turn help them. If a surgeon is referred a range of complex anterior segment pathology in his practice, being able to use a pars plana approach is a tremendous advantage. Not using these techniques puts one behind the curve. If a training program is not incorporating and teaching these techniques for anterior segment surgery, I think they'll be rapidly left behind by those that do. Thank you very much for your attention. That's it.
Wow, Steve, that was fantastic.
Thank you.
We expected something very similar to that, and I think you still exceeded what we were anticipating seeing. Some of those crazy cases are just absolutely crazy and amazing to see, which is wonderful surgery. One question I have for you is you mentioned you've gone away from the Zeiss CT Lucia to the AR40 for the Yamani. Can you expand on that? Because the CT Lucia, the haptics are a bit easier to use sometimes.
Yeah, I actually, let me just see if I can pull this up. Give me one sec. What we found, I was actually the first one to report this a few years ago, is in some of these cases where the lens is tilted, what we would find when we take the lens out is the haptics look like this. They're rotated around the optic. And I published this with my son Jordan in AJO, and I still use the lens. I felt it was a problem with torquing and twisting. It's hard to glue PVDF to acrylic, and they drill holes into the optic of the lens. They put the haptics in the holes, and then there's warm aqueous that gets in there, melts the glue, and it's like when you try to unscrew a pickle jar, you heat it, tap it, twist it, and then it unscrews. You've gone past the point of no return. So we were seeing a lot of these cases from colleagues, hearing a lot about this. And although I continued to use the Zeiss 602, eventually I moved to the AR40 for most of my cases. The problem with the PMMA haptics is that they kink. On the left, you can see the Zeiss 602 as PDF, and on the right, that's PMMA. It kinks much easier. The other problem is that the Zeiss CT Lucia is 147, the AR40 is 180. And yeah, that's kind of a tight fit, you know? So at first I started sharpening the haptic, but then I just started doing it without that. And they melt differently, PMMA. It melts into a mushroom, into a light bulb shaped flange instead of a mushroom. But if you hold it right at the tip like this, you can get it to melt down into a nice little mushroom, melting into the forceps. So I've learned how to melt the tip, and I've just learned how to sort of work with these without much aggressive torquing. I push on the optic, push it away from me, just grab it a little closer to the tip and guide it right in. So now I'm using the AR40 for all of these cases, and I've done about 20 of them, and I've had a very good run with it. The other thing is that the AR40 has a full 6mm optic. The Zeiss 602 is really a 5mm optic with an inert carrier. So it's a lot more forgiving lens for these kinds of cases. I'm much quicker to use iris retractors to kind of pull the iris out of my way so I can see what I'm doing. I don't torque and twist the haptics as much. This helps me a lot too. All right. Does that, you know, address
Yes, no, absolutely answers my question. You know, one thing I've always admired about you, Steve, is whenever you get a question, you always provide a very well thought out and detailed answer. So that absolutely answers my question. So thank you.
Great, thank you.
I know
I have a
we've also.
question.
Oh, go ahead, John. Yeah.
No, I just want to mention, so it's always very interesting to see, people pushing progress and paradigms forward. I'm very interested in the history of ophthalmology, seeing how, Kelman and Ridley pushed their ideas forward to give us what we have today. And you mentioned you show these techniques, but do you have any advice about how those who are interested in doing this become the next generation of Steve Safran or Ike Ahmed? It's interesting that it isn't so easy to incorporate this into training.
Well, the first thing is, when I started doing this 30 years ago, I would show up at, conferences, in Philly and stuff, and, talk about pars plana vitrectomy, and people looked at me like I had, arms growing out of my forehead or something, like I was out of my mind. But, I always felt this was the best approach, and I've, always been friendly with retina guides, and, we all agree this is the best approach. It just there's been this turf battle, I guess. I don't know. But in the beginning, when I was doing these cases, every time I did it, I had to worry about a complication and the risk that I would get sued because somebody would get up there on the stand and say I shouldn't be doing these cases. But after you do a few thousand of them and you start getting referrals from, university retina specialists for these cases, you feel pretty comfortable that you're, somebody that people, oh no, Steve knows how to do this. He's good at it. And they're not just going to say, well, he shouldn't be doing this. So the first obstacle is this, medical legal thing. Should we be doing this? And 30 years ago, most people didn't think we should be doing it, and I had to overcome that. Now, fortunately, there's plenty of courses and plenty of, advocacy for middle segment surgery and anterior segment surgeons to do these kinds of things. So guys who want to get into this don't have to overcome that medical legal barrier, which for me was, really like a concern. I mean, any little complication could be a lawsuit. Now, a complication is a complication. It can happen to anybody, okay? But I think if my 260 videos showing what I've been doing for 30 years makes me sort of, accomplished that this people would acknowledge that. Number two, I think training programs need to indoctrinate residents in these techniques, and many of them do. They can get their feet wet, but it's certainly not enough. I think that, look, I learned how to do DSEC, DMEC, LASIK, tubes, plastic. So many of the things I learned to do, I learned in private practice. You know, I mean, a lot of guys had to learn phaco, which was their bread and butter in private practice. So you can learn these things. But the one thing I will say is this is not something that you dabble in. I mean, you have to decide, is this something I want to do? I want to get into, I want to be good. I want to do these kinds of cases on referral. Or is it, you know, something I want to be aware of and refer it to somebody who does these cases? But the first thing is the people who do these cases, I think, should be using these techniques, whether they're retina trained, glaucoma, or cornea trained. These are the best techniques to manage these cases. I only showed cases that really could not be managed without these techniques. Not, you know, my best cerclage or my fanciest case. The cases where pars plana vitrectomy is integral to the management of the case, and without it, I could not have done the case. So I think that the surgeons who are doing these kinds of cases on referral should be skilled with these approaches, whether their background is from the front or the back of the eye, they're going to meet in the middle. I don't think you can dabble in this, but I do think that if a surgeon loses vitreous in a routine cataract, it should be part of his training to put a trocar in, do a pars plana vitrectomy with the anterior or posterior infusion, and do a really skilled, good vitrectomy for that patient. And then he can decide whether to put the lens in the sulcus, leave the patient aphakic, do Yamani. But please, you know, I think it's avoid the anterior chamber lenses because those are a real pain for me to have to take out and deal with the complications of. There's so many better options now. I mean, Yamani is just such a fantastic procedure. It's good hands. Was that, I hope answers that question.
So I guess I'm the sole retina person on the panel, so I should try to represent the posterior segment. And
Right.
first of all,
Come
I'd like
again,
to,
Papa.
no, it was a great talk, Dr. Safran. I mean, I congratulate you on showing some great cases. You're obviously a very talented and accomplished surgeon, and you're very versatile as well. You know, I agree with you. I mean, if you want to tackle these cases, I mean, it's best done through the pars plana. I mean, that's my exclusive approach. I guess, you know, in terms of training, we certainly encourage the residents to come with us, but you know, there's a critical number or volume of cases you need to do before you're comfortable doing some of these maneuvers. And as part of doing, you know, it's not just doing a pars plana vitrectomy, you want to do a good pars plana vitrectomy. And so I'm glad you showed, you know, that you can encounter retinal breaks that need to be dealt with. I think, you know, part of a good vitrectomy is making sure the posterior hyaloid is elevated. And surprisingly, sometimes we get, you know, 85-year-old patients with a drop lens where they're, you know, they have no PVD and you have to induce a PVD. And every time you do that and manipulate the anterior vitreous, there's a chance of peripheral breaks, sclerotomy breaks, even with insertion of trocar cannulas. So, you know, hopefully you're doing a scleral depressed examination through the ReSight or the biome system, identifying breaks. And I think anyone doing this, you know, as long as they can identify breaks and treat breaks and hopefully even tamponade breaks when needed, you know, you can be relatively safe. But without that, you know, we do know that the chance of sclerotomy breaks and peripheral breaks, even with a relatively routine vitrectomy, is 4 or 5% and higher if you're doing more complicated maneuvers. So that's my 2 cents.
Yeah, no, I do, you know, I didn't show, you know, the full vitrectomy that I do. I mean, I've spent time observing my retina colleagues, watching YouTube videos, learning as much as I can about how to do the best possible vitrectomy I can do. I don't do, you know, gas fluid exchanges and membrane peelings. I have removed vitreomacular traction in some cases, but I mean, that's not what I'm trying to do. If I see a case that I think I need a retina colleague, I'll get them involved in the case. If I refer a patient, they've got asteroid hyalosis and they don't have a PVD, I'll send that to the retina guy and he can decide whether he wants to do it because I don't want to be inducing PVDs. That's not really what I want to do. But here's the thing. Your risk of developing a retina detachment is no higher if you're doing an anterior vitrectomy than if you're doing a pars plana vitrectomy through 25 gauge trocars. The difference is if I see something that I don't like, I know it's there. I see it on the spot, and that patient's going to see retina very, very soon. So I've seen things and I don't like them on the table. If I'm comfortable, I'll treat it with a laser. But that patient's seeing retina that same day. And I've had patients where I've gone back there and I've seen a retina detachment I would have not seen. The cornea was not that clear, but I could see it. I do what I can do. I do my IOL. I do my whatever I'm DSEC. The patient sees retina, and sometimes then they get treated by retina. But that's what I mean about working together. I mean, if you do a case and the pressure's 50 and you can't get it down, you send it to a glaucoma guy on staff. We work with each other. But 99% of these cases I can do by myself, and they do well. We follow them closely. I have them see retina if I think it's appropriate. So I don't claim to be a retina specialist, but I don't think I'm increasing my patient's risk with these approaches. I think I'm reducing them because I think I do a better vitrectomy with the pars plana approach. I think it's a safer vitrectomy, more controlled, and I can see what I'm dealing with. And if there's something there that is not a good thing for the patient, I can refer it appropriately.
Okay, thank you. We also have Sadir Hanush here from Will's Eye, and I'd love to hear his thoughts on this case as well, or on this presentation.
Thank you, Dr. Rai, and thank you, Dr. Lloyd, for inviting Steve to speak. Obviously, an amazing talk. Actually, I would use the word transformational to describe what Steve is doing, and we're very grateful to him for helping us advance our middle segment surgery movement. I think we're on to great things. I'm just going to make a few comments that would be helpful to the faculty at the University of Toronto. Steve, myself, and Professor Coronio from Sydney, with the leadership of one of your own University of Toronto fellows, Erica Darian-Smith, have done some work on collecting statistics on how many cases are required to get facile at these procedures. And we've incorporated them into a journal article. Hopefully it will be published soon. So Erica is working on this very hard, and hopefully it'll be in the European Journal of Ophthalmology very soon. So we are, as part of the movement of middle segment surgery, we are trying to work with section chiefs, retina, cornea, as well as department chairs around the United States and North America. But here are the stats that I think are important for everybody, and it came up in your questions, Dr. Lloyd. So we do 4 million cataracts in the United States every year. We think that about 4,000 cases need to have secondary intervention. And maybe Steve is comfortable addressing 4,000 cases per year, but it will be kind of a challenge. So we've done some research on this, and to be facile with these procedures, we think that we probably want to be doing 2 cases a week, and that will require a catchment area of 1 to 1.5 million population, meaning at an incidence of, let's say, 0.1 or 0.2% complication rate that has to be referred for secondary work. So this is a movement in progress. I completely agree with everything Steve said. I think what my dream is to get the vitreoretinal surgeons comfortable with anterior segment phenomena. First of all, stop using anterior chamber lenses, which did happen in 2017 at both your institution and our institution. I don't think any of our vitreoretinal surgeons are doing that anymore. And then be respectful of the trabecular meshwork, of the corneal endothelium, and biometry to calculate implant powers. This does not have to be the domain of an anterior segment surgeon. A vitreoretinal specialist can do the entire work with the goal of best unaided vision at the end of the procedure, just like an anterior segment surgeon can do a basic pars plana vitrectomy. And we don't have to pick up lenses off the macula unless we're comfortable doing that. So there will be training in our programs, as well as post-residency training opportunities. Arturo Shayat has offered people to come to his clinic in Tijuana to have hands-on training for 2 or 3 days. It may not be enough. In the final analysis, you have to have a critical mass. These are not going to be generated in an individual practice. So if you look at CARINET and you see the questions being asked on CARINET by people who have 1 or 2 of these cases per year, you're never going to get facile at doing those. Regarding medical legal issues, I think Steve covered it beautifully. I think we've come a long ways there. We still have to deal with hospital privileges, and we have some thoughts on how to advance those. with the support of our retina service and our ophthalmologist in chief, Dr. Julia Haller, who happens to be a vitreoretinal surgeon. I'll stop here. I know you have to move on to your resident rounds very shortly.
Thank you, Siddhar. Your input is welcome, and your leadership on middle segment surgery is excellent. And we do have Ike here. I think he's done one or two of these types of cases. I don't know if he's got any thoughts for us.
Well, Steve, my friend, it's always great to see you. Steve and I go way back. We used to have 2-3 hour conversations evenings at ASCRS. So great talking, great to hear everybody. Just to switch gears a little bit, Steve, you know, I do use iris suture lenses a lot, and I find the need to do vitrectomy is less, and there's less manipulation. So I just want to get your thoughts on that. Obviously, I know that you may have some thoughts about iris suture lenses, but I think like any other approach, it does require proper technique. But I think it's an option that may be useful.
Well, I didn't hear what you said. What kind of lenses? You said I use.
Oh, iris sutured approaches, iris sutured lenses. I do use this a lot, actually. I find it to be a good choice, and there's just less manipulation. I know you're going to say complications, but we see lots of complications with the Yamani too, man.
Well, there's a couple of things. First,
Technique.
Yeah, I see complications from the Yamani. I end up redoing those. They get sent to me and I fix them. But I can be honest with you, my Yamani, that has been the least complications of any, you know, sutured lenses. They do very, very well over time. I'm really surprised how quiet these eyes are and how well they do. But that's with good technique and a proper vitrectomy. You know, to me, suturing hardware to a highly innervated vascular structure like the uveal tract is a bit like wearing a belt around your testicles to hold your pants up. I mean, I'd rather use my hips. You know, there's a lot more. I mean, we suture tube shunts and buckles to sclera. It's very robust. It's strong. It's very supportive. I mean, the idea of suturing to uveal tract when you've got sclera there just doesn't make that much sense to me. The other thing is, you know, patients have a lot of pseudophagodenesis with the lens suture to iris. I have a lot of patients who had iris fixated lenses. I did a scleral fixated lens in the other eye, and they told me optically it's so superior because of the stability. They don't have that shimmering of the image. And I've seen plenty of cases of UGG syndrome from scleral fixated lenses that, you know, the surgeon who did it didn't even realize that they had. They come to see me, they have glaucoma, the pressure's high, and, you know, they got pigment in that eye and the angle they don't have in the other eye. I take the lens out and things quiet down. So, I mean, me personally, I never liked iris fixated lenses. I've done, I think, very few of them because I just don't like them. And I'm such a big fan of Yamani that I just think it's a better approach. So that's what I do.
Okay, well, we'll give Steve the last word. We do have to move on to resident teaching. And Steve, I appreciate you taking the time to teach our residents this morning as well. I hope they recognize what a privilege it is to have you here. Great round this morning. I do want to thank John for facilitating this, and Siddhar and Ike for joining us with their expertise. I hope everyone has a good Friday. Steve, thank you once again for a wonderful talk this morning.
Well, thank you for having me. I'm very grateful for the opportunity. Thank you.
Thank you, everyone.
And Steve, and I hope you've inspired one or two of our residents to follow in your footsteps. So thank you.
Well, that's the very kind words. I hope that I just want to have a little fun with them and teach them some things they might not hear so readily from other people. Hopefully, it's nothing too controversial.
All right, enjoy, guys. Bye.
How long a break do you want me to take before I start with the residents?
Sandra, should we give him 15 minutes?
15 minutes?
Yeah, let's do 15 minutes. We'll go at 9 o'clock.
All right. So 9 o'clock we'll all meet, and I'm going to grab a bite. All right.
Thank you.
Thanks.
Bye.
You all.